All right. So for a patient receiving mechanical ventilation, we already discussed the settings last week. I'm going to the nursing care now. All right. So what did you remember that I said about when we talked about cardiac monitors for 241? Who do you take care of first? The equipment, the monitor, or the patient? Okay, so regardless of what the monitor is showing, what do you do first? Go assess the patient. Okay. So same thing here. So you'll see alarms, you'll hear alarms, you'll see something going on, lights flashing. Um, Always assess the patient first. So we enter the room, don't go looking at the ventilator. Okay, look at the patient first. Okay, look at the patient. How's the patient doing? Is the patient breathing? Right? Right. So no matter what the alarm is saying, look at the patient first. Okay, and then look at your ventilator. And what did I say is the mechanical ventilator? What is it? It's a glorified what? It's a glorified ambu bag. So if anything fails, let's say the ventilator's not working, what do? Disconnect the patient from the vent and then give manual breaths. Okay, that's the best thing you can do. If let's say there's alarms that you can't fix, absolutely. The ventilator is not working, for instance, although ventilators have batteries, meaning they have backup power for about 2 hours. Some ventilators can even power up to 4 hours. Okay, so sometimes they malfunction. So what can you do again? Do you have to have the another ventilator, which is found in the basement? Okay, so the respiratory therapist has to get you a new one in the basement, and depending on what floor you're at. Okay, so what do? Okay, disconnect the patient and give manual breaths. Okay, until we can fix the problem or we can get a new working vent. Now the nursing care is in the paragraph. I mean, there's no bullet points here, but there is one down here. All right, so these are your um, responsibilities. Take note, I did not read the paragraph. That's for you to read. The paragraph will explain the rationale for each action listed on the bullet points. Are we clear? For instance, see here what your assessments are. So this is what I mean by look at the patient. Okay. So sometimes our equipment don't usually reflect the actual reading. So let's say the pulse oximeter is showing you the patient is 60% FiO2. 60% oxygen saturation. Look at the patient. Does the patient look like they're at 60% saturation? Okay, so what would somebody with a 60% saturation look like? They look blue. Okay, they'll look cyanotic. Right? So for the patient's color is wonderful. Okay, you get good capillary refill. Is that really accurate? Probably not. Okay. So always place the patient on 30 degrees. Okay. Remember our ventilator associated bundle. So what are those four again? No, actually we have five actions in preventing VAP, ventilator associated pneumonia, which is likely to occur 48 hours after initiating mechanical ventilation. So what are those five? One is elevate the head of the bed 30 degrees. What's another one? Oral care. How often? Every 2 hours or as needed. Do we do PPI? Yeah, we give PPI. And then finally, no, number four is DVT prophylaxis. Okay. And then finally, number five, suction as needed. Okay, so here are our overall responsibilities for all patients receiving mechanical ventilation. Make sure the mode that is ordered is correct. The settings are accurate. tidal volume, your rate, okay, FiO2, they're all correct. PIP, sensitivity and the trigger. Now, I to E ratio is normal I to E ratio, like for us now, is 1:2, meaning it takes 1 second to inhale, 2 seconds to exhale. Okay. Now, if the patient is on a vent, it's usually the same. So 1 second, the ventilator will deliver the breath over 1 second, and then stop delivering a breath. The patient exhales over 2 seconds. Make sure there's humidification, because otherwise the patient will be very uncomfortable if dry, cold air enters the lungs. And alarms. Even though this says here that alarms should be turned on at all times, ventilators, modern ventilators today, do not allow you to mute or silence or disable any alarms. All you can do is pause the alarm for 2 minutes. That's all you can do now. During when I went to school, vents, we still had that option, meaning we can disable the alarm because sometimes it's just annoying. Okay. But people died, patients died because we disabled the alarms. So now even if we wanted to, we could not. Okay, so ventilator alarms can only be paused. They can never be disabled anymore. All right, let's discuss PEEP. I know we did not get to do this. So what is PEEP? Let me illustrate. So let's say this is zero pressure. This line represents no pressure. So ordinarily, like you are now, you and me, we're breathing this way. So we are negative pressure ventilators, so negative trigger, and then we go, and then exhale. And then the pressure goes straight down to zero at the end of exhalation. That's how we're breathing. When a ventilator is giving a breath, where does it start again? Above or below zero? It's a mechanical ventilator. Above, right? Because they are positive pressure ventilators. So they give you a breath up to the set tidal volume. However, at the end of exhalation, it does not go to zero. Now, this is called PEEP. PEEP stands for positive expiratory and pressure. This is actually genius because what PEEP does is, since it does not allow the pressure to go to zero at the end of exhalation, therefore, even if we have higher FiO2, remember mechanical ventilators start at 30%, right? Sometimes you can be at 20 below 30, but usually 30% or higher can go all the way to 100% FiO2. Now, the beauty of PEEP is, instead of giving the patient high levels of FiO2, we can instead add PEEP. So we can increase PEEP from 5 to 10 to 15 or even 20. Okay. However, the PEEP should never be higher than 15. Usually, most patients, stable patients, they have a PEEP of 5. The reason is, if you think about it, the If this is the patient's heart, and this is the right lung, and this is the left lung, what's happening to the heart at the peak of inhalation? Right here, at this point here, at this moment in time, at the peak of inhalation, what's happening to the heart? Here, at this period right here, in this cycle of your respiration, what happens to the heart? Tanisha? Okay, it's being squeezed by both lungs. And remember, this is a positive pressure ventilator. So equal or higher pressure than without a vent. Higher, correct? Okay. So the patient on a mechanical ventilator has higher intrathoracic pressure because we changed the physiology. Instead of them breathing on their own as a negative ventilator, now they become positive ventilators, right? Because of the mechanical vent. So therefore, what happens to venous return and therefore cardiac output during this period here? At this point right here. At this point, what happens to venous return and cardiac output? It decreases only for a moment though, right? So if you think about it, right here under normal respirations, you and me, right now we're not on a vent, pressure goes to zero. So therefore, the heart is released. There's no pressure exerted against the heart if it goes to zero pressure. There is a little bit right here because what it does is it doesn't allow the alveoli to completely close. They do not completely empty because there's still pressure being exerted at the end of exhalation at 5, 10, 15, or even 20. The limit usually is around 15. We can put the patient on 20 centimeters of water, PEEP, only for brief periods. So let's say 1 or 2 hours, that's it. Because we know what happens to cardiac output if your PEEP is too high, it drops your cardiac output. Okay, so yes, we may need to, you will see, this is only done in the ICU. Okay, we usually don't raise PEEP on any other unit except the ICU. So people on long-term care, for instance, they all have a PEEP of 5. Okay, or even stable patients on a med-surg floor, med-surg unit in the hospital, they also have a 5 centimeter PEEP. Okay, so the benefit of PEEP is it actually prolongs the gas exchange cycle, the period for gas exchange. Because if you think about it here, when we breathe, when is actually gas exchange occurring? When is it actually occurring? During inhalation or during exhalation? No, the actual exchange of gases. When does that occur? During inhalation or exhalation? Inhalation. Here, by adding PEEP, you actually extend the gas exchange period, meaning even toward the end of exhalation, gas exchange is still occurring. Okay, rather than going to zero, wherein absolutely there's no gas exchange here. Here, if you add some pressure at the end of exhalation, then you are still promoting gas exchange. Okay, so this benefits the patient, especially if you have higher FiO2, then you need PEEP, okay, to prevent what we call absorption atelectasis or lung collapse due to increased FiO2. Okay. Another thing here, when your patients are intubated, let's say you work on ICU or wherever you work, because of the sudden change, because a moment ago, was I on a vent? No, I was a negative pressure ventilator, right? So my end expiratory pressure was zero. Now, all of a sudden, how long did it take again to put a airway in me with today's method or today's protocol? 30 seconds, right? 30 or even 20 seconds. It's already in because we use rapid sequence ventilation. So 30 seconds ago, I was a negative pressure ventilator. Now 30 seconds later, I am now a positive pressure ventilator because you hooked me up to a vent. So now, are there changes in the physiology inside the thorax? Did that occur slowly or suddenly? Suddenly, like this. Okay, so the body doesn't know what's going on. Hey, what is this? Hey, why is the pressure suddenly too high? So expect some level of post-intubation hypotension. Okay, so some patients, not all, okay, the older or the higher the comorbidities of the patient, the more likely they will experience post-intubation hypotension. Okay. Now, we did not intend to do this. We needed to intubate the patient and put them on a ventilator for some reason. As a consequence, though, there will be hypotension. So expect the doctor, if that occurs, then the doctor will order vasopressors. Okay, remember norepinephrine when we talked about shock? Okay, so those same medications will be ordered, either norepinephrine, could also be phenylephrine, but yeah, either of those two. Okay, so vasopressors will be ordered in order to maintain MAP of 65 or better. All right. I just want to mention it because it's not really discussed in the textbook. But that's one of the consequences, okay, right after intubation. Here's a warning about never get used to pausing alarms. There's alarm, the alarms are on for a reason, meaning why is there an alarm? Because something's wrong, right? So you need to deal with the problem rather than just keep silencing the or disable, pausing the alarm. Okay. So here's what I mentioned earlier, cardiovascular compromise. So this is post-intubation hypotension. So there's a decrease in venous return because of the positive pressure applied to the lungs. Okay, so that's one of the problems. Okay, so one frequent problem, actually two frequent problems are either high pressure alarms, which will cause an increase in peak airway pressure, or it's a decrease in pressure, which will trigger a low pressure alarm. So the most frequent of the two is a high pressure alarm. High pressure alarm can be triggered by the following. So in this table, how you study for it for the final is middle column is the cause, and then your solution, your nursing intervention will be on the third column. Okay. It's a long list, okay, of causes that will trigger a high pressure alarm, but all of them do the same thing. They increase the resistance between the ventilator and the patient's lungs, meaning it's harder, the ventilator is meeting increased pressure, higher than expected, okay, to deliver a breath into the patient's lungs. One reason would be the patient is coughing, or there's a mucus plug, there's something obstructing the airway, such as secretions, for instance, really thick secretions. Another is, remember AC mode, wherein the patient is getting better, taking more breaths, and then they have breath stacking. Okay, so that is patient ventilator asynchrony or desynchrony. Decreased lung compliance, the patient's lungs got worse. Maybe they develop ARDS, okay, moments after the intubation. Or there's a kink tubing, the circuit is kinked, or maybe you're stepping on the circuit, maybe it's under your foot. Patient had a pneumothorax, meaning the pressure was too high, ruptured the patient's lung, and then now there's air in the pleura. Or the patient's lungs collapse for some reason. Okay, so all of these trigger what type of alarm again? High pressure alarm, causing an increase in peak airway pressure. The other alarm is low pressure alarm. This one is the patient's lung compliance increase, meaning the lungs got better. So we need to make changes to the pressure. Or there's a leak in the ventilator tubing. And another one that's not mentioned here is maybe the patient extubated themselves, meaning they woke up because your sedative bag is empty or your opioid bag is empty. They woke up and then they wondered, oh, what is this tube in my mouth? So they pulled it. So now, is there any resistance? Zero resistance. Trigger low pressure alarm. All right. So can it also be a leak in the cuff, in the endotracheal tube cuff? Yes, that can also be low pressure. And I already mentioned about the post-intubation hypotension, which is cardiovascular compromise. Okay, barotrauma. Baro means pressure. Okay, so barotrauma. Are our lungs used to positive pressure ventilation? We used to something forcefully shoved down into our lungs? No. Okay, so we are negative pressure ventilator. We're supposed to work like a vacuum, right? We suck in air. This time, the air is now being pushed under positive pressure. So can the alveoli withstand that forever? No. So over time, some alveoli will rupture. Okay, especially if you don't monitor your settings. The peak airway pressure has been going up over the last few hours, and then you never reported it to the doctor. So that can cause barotrauma. Okay, literally the lungs will rupture because of the pressure, and then the pleura is intact. So of course the air escapes out of the lung and gets trapped within the pleura, causing a pneumothorax. So the patient will require a chest tube in that case. Pulmonary infection, this of course is referring to ventilator-associated pneumonia. So we use our 5 interventions in the bundle to prevent it. Other problems are delirium and post-ICU syndrome. Now, this is a natural phenomenon caused either by the multiple medications we're administering in the ICU and also from sleep deprivation. Now, the constant monitoring, the constant turning, because we have to turn these patients every 2 hours, do mouth care every 2 hours, suction as needed, alarms going off every few seconds. So, will the patient have any restful sleep? No. So, of course, anyone who is sleep deprived eventually will experience delirium. Okay. We actually call that ICU psychosis. Good thing is it resolves once the patient, of course, gets enough rest. Ensuring gastric change again is because the patient is sedated when they have an endotracheal tube. So therefore, what's the only basis we can use to evaluate whether our therapy is effective or not? ABGs. And suction as needed. Preventing pneumonia again, ventilator-associated pneumonia. That's preventing injury and infection. The other injury here is, of course, the pressure injuries. Okay. So turn your patient as scheduled. If the patient, in the rare instance that they extubate themselves, meaning they pull the ET tube because again they woke up, okay, you did not monitor the patient well. So the it's traumatic, okay, because the cuff is inflated and then they forcefully pull that ET tube, then it can cause harm to the trachea as well as the larynx. May cause laryngeal nerve injury and then edema and constriction of the bronchus. How do we prevent this again? We have what? How do we secure the tube? Commercial tube holders. Okay, so just like with your tracheostomy, you had a tracheostomy ties, right? So we have endotracheal tube holders as well. Once the patient is on a vent on a trach now, which means they require the intubation beyond 2 weeks, then we can get them out of bed. Actually, we can put them in a chair or a wheelchair or even sit them up in bed, okay, if you have those types of bed. Communication, again, once they're off sedation, meaning they have a tracheostomy already, then we can communicate. Okay, so either the patient will mouth their words or write on a whiteboard or use communication boards, okay, or a Ouija board. That's it for mechanical ventilation and complications. Any questions? Okay, very short. Last topic is on chest trauma. I won't repeat chest tubes. We did that last semester already. The only two questions on chest trauma, there are 4 types of chest trauma. It's only signs and symptoms, and then your interventions. What are they again? Signs and symptoms and interventions. Okay, so let's start. So imagine your lungs. Can you touch your lungs? Why not? Okay, there are many layers of protection, correct? So first is your chest wall, and then underneath your skin, there's a little bit of fat there, not much, and then there's muscle, correct? Then there's there's fascia, and then there's muscle, and then you have your rib cage. Okay, so the rib cage protects the delicate structures in your thorax, which are the lungs and the heart. So therefore, to get to your lungs, to injure your lungs, what must you therefore sustain at the same time? Chest trauma as well. Okay, so for instance, let's go to rib fractures. Okay, so in order to injure the lung or the heart, you have to apply either blunt force or penetrating trauma to the chest wall, meaning to the chest muscles and to the ribs, right? Before you can reach the lungs. You have to penetrate those defenses first. But is it possible that in the process of breaking a rib, the rib can puncture the pleura and the lungs or your heart? Yes. So therefore, what I'm trying to say is when you have a patient with chest or lung contusion, for instance, chest trauma, always consider there are multiple, correct? Because in order, again, before you can reach your lung, meaning you have to go through several tissues, okay, several structures in order to get to the lungs. So always consider multiple types of trauma. Okay. So starting with sternal and rib fractures. So here are of course, the causes would be any blunt or penetrating force trauma. Manifestations, chest pain. Okay. And then when you look at the chest wall, there is tenderness. What is ecchymosis? Well, it'll just be bruising. Okay. Ecchymosis is bleeding underneath the skin. Okay. Crepitus would be, how do you describe crepitus? Like tiny grinding of teeth sounds, okay, like that. Okay, so that's crepitus. And then there's swelling, and then the patient, of course, is guarding that area, and the patient is complaining of pain, especially when they cough, deep breathe, or move around, right? There may not be any open wounds, okay, especially if it's a blunt force trauma. Let's say a car accident, for instance, you hit yourself over the steering wheel, or any other object around the car, for instance. Okay, so there may not be any outward signs of bleeding, but doesn't mean there isn't bleeding anywhere inside. So let's say if the fractured rib is displaced, and of course there are sharp edges now, right? And then that can puncture your lungs or even puncture your heart. So for our intervention, so we need, of course, to diagnose X-ray, okay, in order to see what are we dealing with. And then here's the management. So patient will be, if there is a displaced fracture, then the patient will go to OR. They'll, just like any other fracture, they'll fix it. They'll use plates, rods, screws, okay, to um, fix the fracture. And if needed, then chest tubes will be inserted if the patient also developed a pneumothorax or a hemothorax. And then lots of pain management. All right, flail chest. Unlike rib fracture, wherein the rib was only broken in one place, for instance, show you a picture. A flail chest is also a broken rib. But here's the difference between the two. Okay. If the rib is only broken in one place, like here, imagine this part here is not broken, right? So just in one place. Let's say you had a car accident and it was broken right here. Okay, you have multiple rib fractures, but there's only a break in one segment. Okay, so that's called a rib fracture. A flail chest, however, is when a rib is broken in more than one place. They could be broken in two or more places, which results in a independent floating segment. You've eaten baby back ribs, right? You've eaten beef, pork, ribs. Yeah, tastes good. Yeah, very tasty. Okay. Now, what's holding the rib really in that dish that you have? What's holding the muscle? I mean, what's holding the rib there in place? It's the muscle, right? Okay. So imagine here, again, if it's a fracture, it's only broken in one segment. In flail chest, the rib is now broken in two or more, meaning this will pose a problem with chest expansion, because if it's broken in one segment, the chest will still expand because this part of the rib is attached to this part of the rib. This section here is attached to the sternum, and then this remaining segment here is attached to the spine. So of course it will move. Okay, so when the lungs expand, it will hurt, of course, but at least the lungs will expand. It hurts, but it will expand. However, if it's a flail chest, which means it's already broken in more than two spots, this section here is connected to the rib. This one's connected to connected to the sternum. This one's connected to the sternum. This third part is connected to the spine. This is connected to the spine. This is connected to the spine. What are these three floating segments connected to? Nothing. So what's holding them in place? Just the muscle. Okay, so therefore, what will happen when the patient inhales? What will happen to this segment right here? So this is what we call a paradoxical chest movement now. Here's the illustration. So when you have a flail chest, this segment here that has floating ribs that are not connected to the sternum or connected to the spine will push in during inhalation because nothing's holding it. So when you inhale, that segment will cave in. Okay, so that's what we call paradoxical. What does paradoxical mean? Opposite, right? Paradoxical chest movement. So when you inhale, what's supposed to happen to your chest? Supposed to expand, right? And then contract during exhalation. So what's happening here now? When I inhale, this floating segment will actually cave in. It will be sucked in because nothing's holding it. Because as these two, this part here and this part here will expand when I inhale, but these sections here wherein nothing's holding them except just the muscle, they will of course cave in. So that's your manifestation. So if you see paradoxical chest movement, and watch also what happens to the internally. If that's what's happening, so therefore there is positive pressure created, correct? So it will push the heart out of the mediastinum. It will push the heart toward the opposite side. And you know the heart has to sit in the mediastinum. If you push the heart in either side, what will happen to the superior and inferior vena cava? They will get compressed. So what happens to venous return? What happens to cardiac output? Also decrease. What type of shock is this? Obstructive shock. All right. So those are your manifestations for flail chest. So between the two, of course, which one is more of an emergency? The flail chest will require emergency surgery. Until then, though, the patient may require a chest tube first, okay? Because airway is priority, right? So we have to stabilize the patient's airway and breathing. So stabilize that first, and then we'll get the patient to the OR once we have the chest tube inside. Okay, because we need to evacuate. Of course, because when you have that type of injury, that means there or is there no hemothorax or pneumothorax? Definitely there is a pneumothorax or hemothorax. Definitely it punctured the lung or the pleura. So just like I said, so any other fracture, flail chest, we will have to reduce the fracture, okay, using plates, rods, screws, okay, to put them back in place. Contusion is actual laceration and bruising on the lung tissue itself. Now, for this to happen, that means have we injured the chest wall and the ribs as well? Yes, in order for you to to injure the lungs, then that means there's several other tissue layers that were injured at the same time. Okay, so just focus on the um, signs and symptoms, meaning we need to recognize what injury is it? Contusion? Is it rib fracture, or is it a flail chest? Okay, and then if chest tube is needed, we already discussed chest tube management last semester, and then we also just concluded intubation and mechanical ventilation if needed. All right, and then that's it.